Adherence Management Coaching (AdM Coaching) is an evidence-based applied behavioral approach for significantly improving patient adherence and reducing unplanned hospital readmissions. It is based on the research and work of Bob Wright, Aubrey and B.F. Skinner. AdM Coaches identify patients at high risk for readmission as a direct result of not following their discharge plan. Once identified, AdM Coaches work with these patients, patient engagement, to identify consequence analysis with their plan of care that might result in non-adherence. Together, with their provider, AdM Coaches establish a patient-centered adherence improvement plan (AIP). The AIP is used to identify target behaviors, desired results, clinical outcomes, and reinforcers that support following their plan of care and developing adherent habits. Following hospital discharge, at-risk patients, and their families, are followed and coached by an AdM coach for several months as the adherent replacement habits are developed and strengthened. Home and work environments are filled with cues of a lifetime of habits. While meeting with at-risk patients and their families, AdM Coaches identify these cues and work with the family to replace them and reinforce healthier habits. All new behaviors, if not reinforced, will return to the lifestyle habits that contributed to hospitalization in the first place. Adherence management provides a coaching toolkit to be used in conjunction with teachback, motivational interviewing, pill counting, biochemical measurements, pharmacy database of usage, and directly observed treatment short course dots. Worldwide, half of all patients choose to not follow their plan of care. Current programs, like the teachback method, focus on teaching all patients, just prior to their discharge, the new information they need to follow to once they go home. Motivational interviewing takes more nurse-educator time as together, with the patient, they attempt to identify and overcome areas of ambivalence concerning their disease process and plan of care. Other programs focus on alerting devices and pill minders to aid patients in remembering to take their medications on time. At best, these cues or antecedents have had a marginal impact on improving adherence. The Centers for Medicare and Medicaid Services has extended provider responsibility and accountability well beyond the front doors of clinics and hospitals. CMS, in responding to a hospital question concerning levels of responsibility following discharge, responded writing, "Post-discharge care is a joint responsibility." Punitive programs have been established within the Affordable Care Act of 2010 as a quality incentive to create change. Hospitals with readmitted patients, above an allowable range and within 30 days of discharge, lose a 4% quality withhold. A significant number of these readmissions, because of a lack of post-discharge transitional care coordination and patient engagement, will be the result of non-adherence to their discharge plan. Punishing hospitals for patient non-adherence may have some effect on hospital behavior, but little or no impact on improving patient adherence.